Today, my talk is titled Emerging Techniques for Imaging Stroke Pathophysiology. And started. So these are my disclosures. None of them are really directly relevant to anything that I'll be presenting today. The talk is structured as follows. Basically, I thought I'd start with a relatively brief review of the pathophysiology of acute ischemic stroke. And there I'll be trying to really focus mostly on the clinical aspects of stroke pathophysiology and how they're important to actually how we manage and treat stroke patients in clinical practice. And then I'll be moving on a little bit to how we can image cerebral pathophysiology or pathophysiology in the setting of acute stroke. And there's a lot to talk about, but I'll kind of be focusing mainly on two things: the imaging of blood flow, perfusion, and the imaging of functional connectivity. And even then, I'll kind of be limiting myself mostly to certain novel methods that have emerged over the past few years for imaging these pathophysiological processes. And at the very end, there's just going to be a very brief slide on some future directions, and we can talk about those more during the discussion if there's interest. So as you all probably know, stroke is a very common cerebrovascular disorder. It's associated with a very, very high mortality and morbidity kind of worldwide. And the basic kind of characteristic of stroke is that it's a cerebrovascular disorder or a neurological disorder that's caused by the interruption of the blood supply to an area of the brain. And this area of the brain then subsequently basically becomes damaged. And there's two main types of, there's two main types of stroke. So two things can basically cause this interruption of the blood supply. The more common subtype of stroke is ischemic stroke. So it's caused by the blockage of a blood vessel by a clot. And the less common, but still in relative terms less common, but in absolute terms actually still very common subtype is hemorrhagic stroke, which is caused by the rupture of a blood vessel supplying part of the brain. That's known as an intracerebral hemorrhage. And those are the basic subtypes. And when we're thinking, when a patient comes in basically to the hospital and they're suspected of having had an acute ischemic stroke, which is kind of most of what I'll be talking about will be focused on. The treating clinicians, everyone who's involved basically in the management of that patient, is keeping certain things in mind. There are certain kind of pathophysiological processes that we have to keep in mind because they really directly influence how these patients are treated. And I've just summarized them here. They're sometimes referred to as the 3 Ps or the 4 Ps. I like to think of the 5 Ps. So the first P is the parenchyma. The second is the pipes. The third is penumbra or perfusion. The fourth is performance or function, basically. And the fifth is pathways, accessory pathways. And we'll be talking about each of these kind of separately in a moment. But the point that I want to make here is that actually MRI is the best modality, perhaps the only modality that can really help us in some way or other, basically visualize and assess these different pathophysiological processes in humans. So there's, I mean, you all know this, I guess, but of course, MRI is an extremely versatile technique. There are all kinds of different sequences that help us basically, at least to a certain extent, probe these different pathophysiological processes that are really, really important for managing acute stroke patients. That being said, of course, I'll be mentioning kind of some other non-MRI modalities as we go along, because in specific situations, some of these modalities might have more advantages than MRI. So one of the most common ones is CT, for example. Computed tomography is very widely available. It's relatively cheap. So it's very often the first line of imaging, basically to exclude certain things when it comes to managing stroke patients. But overall, as a whole, I think MRI offers like the largest kind of repertoire of tools that we have in order to assess these pathophysiological processes. And keeping that in mind, kind of what I think is important to also kind of think about when we're thinking about imaging stroke pathophysiology is that if we want the technique to be clinically applicable, then it has to fulfill certain criteria. There's many of these criteria, but the things that I think are most important is it has to be fast. And by fast in acute stroke, we often mean very, very fast, because every minute, every second counts. Treatment has to be, in order for treatment to be effective, it has to be applied very, very quickly in the setting of acute stroke. So speed is really a very important factor when it comes to what kind of imaging modality or imaging technique is to be applied. It should be minimally invasive because patients have lots of comorbidities, and the more invasive a technique is, the more this invasiveness basically interacts with the comorbidities, and things start to get complicated, and you start to lose time or perhaps be unable to make decisions, basically. So how convenient, let's say, the technique is also really, really important in the setting of acute stroke. And it also has to be robust because acute stroke patients are, of course, acutely ill. So they move a lot, or they tend to move a lot during the scan and so on. So the technique has to be robust to things such as head motion, for example, but it also has to be robust to other interacting pathophysiological processes from these other comorbidities that I just mentioned. So let's talk a little bit about just the fundamentals of stroke pathophysiology. So again, this is going to be focused on ischemic stroke, acute ischemic stroke, so the more common subtype of stroke. And just kind of showing here, depicted here is just like an artery that branches off into an arteriole, goes into the capillary bed, and then into a draining venule. And this black cell here in the middle is just meant to represent a generic neural cell. And so what happens in acute stroke is, as I mentioned, there's a vessel occlusion. So this artery is occluded by a thrombus. And what immediately happens due to this vessel occlusion is that there's a immediate reduction in the blood flow coming into this capillary bed. And this vessel occlusion and the blood flow reduction that occurs as a consequence of the occlusion can be imaged, can be visualized using techniques such as MRI angiography and perfusion imaging. We'll talk about that a little bit more in a second. But what immediately happens as these cells start to start to be starved of oxygen and glucose is that the metabolism of the cells becomes deranged, it becomes abnormal. And this kind of abnormal metabolism has lots and lots of different consequences, and all these consequences or many of these consequences can also be visualized or picked up on by using techniques such as MR spectroscopy and different quantitative MRI techniques. What then happens also really quickly, just a few minutes after the onset of stroke, is that the cells start to swell. So the sodium-potassium pump fails, of course, because there's no longer any ATP, because there's no oxygen and glucose being delivered to the cell. So the sodium-potassium pump fails, and that leads to water accumulating within the cell. And this is what we refer to as cytotoxic edema. So swelling of the cell bodies is shown here. And shortly after, sometimes even simultaneously, the blood-brain barrier, so the barrier between the blood and the brain tissue, the neural tissue, starts to become disrupted. And both these processes, the cytotoxic edema and the blood-brain barrier disruption, can also be visualized using certain MRI techniques like diffusion-weighted imaging and dynamic contrast enhanced MRI, respectively. In later stages of stroke, and we're talking here more about like maybe tens of minutes to a couple of hours, the blood-brain barrier disruption causes blood to leak into the surrounding tissue. So there's bleeding that almost inevitably happens even in an ischemic stroke. It often kind of transforms into a or becomes hemorrhagized. So the hemorrhagic tissue, or sorry, the ischemic tissue starts to become to accumulate blood products. And what also happens is because the barrier between the blood and the brain is so leaky, water starts to accumulate not only within the cells, but also in the interstitial space. So that's what we call vasogenic edema, extracellular water accumulation. And the cells, because of the sustained ischemia, the sustained loss of blood flow and loss of nutrient supply, eventually die, undergo necrosis or apoptosis, and die. And these kind of processes can be visualized using MRI, using T2 star weighted imaging or susceptibility weighted imaging, for example. And the vasogenic edema is quite well picked up on FLAIR images. And it's important to note that many of these pathophysiological phenomena, of course, overlap with each other. The schematic is kind of more intended as kind of a broad orientation for the overall pathophysiology of stroke, but there is overlap between these processes. So let's kind of move on to our first P, the parenchyma. It's perhaps the most common, the most important pathophysiologic process that's being assessed in acute stroke. And there, the first question, the most important question to the treating clinician is this an ischemic stroke or is it a hemorrhagic stroke? So is the stroke being caused by the blockage of an artery, even if it's a very small artery, or is there a bleed in the brain? Because the treatments for these two different kind of entities are completely different. They are completely different. This can be assessed using non-contrast CT, so just a CT scan of the head without contrast, because it is not quite, although it's not very good at picking up early ischemic changes, it is really excellent at picking up on bleeding, so picking up hemorrhage. So CT has a very high sensitivity for hemorrhage detection. Using MRI, we use techniques such as diffusion-weighted imaging to detect the ischemic tissue. We'll talk about that in a second. And to detect hemorrhage, we use sequences or a combination of sequences such as T2 star, susceptibility-weighted imaging, and FLAIR. The other important issue to keep in mind when we're thinking about the parenchyma is that we often need to assess how viable the tissue, the damaged tissue is. And we often do that by trying to essentially date stroke. So some patients are simply incapable of telling us when the stroke started exactly, even though that is really, really important. So to clinicians, basically treating clinicians, one of the most important things to know is when did the symptoms start, because that influences directly the treatment. Some patients cannot tell you that because they have a very severe speech problem, for example, or because they have dementia and they don't remember, or because they were asleep when it happened. Maybe there's many different reasons. And in those kind of patients, basically being able to tell based on just imaging parameters or based on just looking at the images, being able to estimate when the stroke, how old or fresh the stroke is really, really crucial to influencing or to guiding treatment of these patients. And this is can be done. There are techniques now being developed in order to make this kind of this approach also work with CT. They're kind of still in the experimental phase, but the most important kind of way that we are able to actually date strokes in patients who cannot tell us how old the stroke or when the stroke started is MRI, and for that we use the diffusion-weighted images and the FLAIR. So just to dive a little bit deeper into the parenchyma, the concept of cytotoxic edema, I just thought I'd spend a minute speaking about this just because it's really, really central to the pathophysiology of stroke. We know that water molecules within brain tissue or within any tissue basically diffuse in this kind of pseudorandom motion, Brownian-like motion, right? So all around. And what we're picking up on in diffusion-weighted images is the restriction of the diffusion of water molecules, because these water molecules are now within the cell. So inside the cell where there's a bunch of organelles and things like that, where water simply has a lot less space to move compared to outside the cell. And this is shown here on this diffusion-weighted image. So on here, for example, in this right occipitotemporal area here, blood flow is normal. So basically diffusion is normal within this area, while in this bright area here, you have restricted diffusion because that water has kind of seeped into these cells that are starting to undergo necrosis. And the kind of other side of that is that using FLAIR, so fluid attenuated inversion recovery sequences, we're able to pick up on vasogenic edema, which remember is something that happens at least a few hours or a couple of hours after the onset of cytotoxic edema. And together, those two sequences really help us be able to tell kind of how old the stroke is. Is this a stroke that just happened within the last half an hour, or is it a stroke that's been going on for 6-7 hours? So that's kind of one way that we're able to tease those things apart. The second P are the pipes. Basically, it refers to the pipes, and the pipes are extremely important. They've become even more important over the past 8 or so years because we have a relatively new way of treating at least some strokes, mechanical thrombectomy, which is basically an endovascular procedure. So a way that you go in basically through a large vessel in the thigh or in the arm with a catheter all the way up into the cerebral circulation to the area that's occluded, to the thrombus that is blocking the artery, and then actually physically removing that thrombus and unblocking the artery, kind of like you would maybe unclog a pipe. And so the main things that we look at when we are thinking about the pipes in the brain, we're looking for vessel occlusion, so completely blocked vessels. We're also looking for vessel stenosis, so narrowed but not completely blocked vessels, because they also have they can also be relevant for how we treat patients. And perhaps not so much in the context of ischemic stroke, but in the context of hemorrhagic stroke, we scrutinize basically the pipes for, or the vessels for aneurysms, different types of vascular malformations, because they could be a source of bleeding that need to be directly treated in order to treat the bleed. And for this, for the pipes, we have a multitude of different techniques. We've got CT angiography with contrast agent shown here, for example. We have MR angiography with or without contrast agent. This is a tough time of flight angiography without contrast agent here. And then there is what is considered widely kind of like the gold standard. It's quite invasive, but also very, very useful digital subtraction angiography, which is shown here in the bottom right. So the third P are the pathways, or the accessory pathways. These are often referred to as collateral pathways, collateral flow. The idea behind this is just if there's a blockage in one artery somewhere, are there any pathways that can essentially bypass this blockage? So can the blood get to the area that it needs to without going through this blocked artery? And there's two types of collaterals. There are the primary collaterals, which basically they are a result of the configuration of the circle of Willis. So here we see a representation of the circle of Willis. Here are the vertebral arteries, right? They join up to make the basilar artery and then branch out to the posterior cerebral arteries. These are the, this is the internal carotid artery, or the end of it here. That's the middle cerebral artery. This is the anterior cerebral artery. And really importantly, we have connecting arteries. So we have a posterior communicating artery that connects the internal carotid artery to the posterior cerebral artery, and we have the anterior communicating artery here that connects both anterior cerebral arteries. And what this means basically is that if we have a situation like this, where this internal carotid artery is blocked, then blood can still reach the area supplied by this right middle cerebral artery, because there are pathways here, for example, through this posterior communicating artery or through this anterior communicating artery that can deliver blood to that area. It won't be the same kind of blood flow, kind of from a qualitative or quantitative perspective, but some blood will get there. And the fact that some blood will get there means that damage occurs a little bit later. The tissue can kind of sustain ischemia for a longer time than if these pathways kind of were not available. And these kind of collaterals that result from the configuration of the circle of Willis can be assessed using the same techniques that we used for the pipes. So digital subtraction angiography, CT angiography, especially dynamic CT angiography, because very often you want this information about the timing of the blood flow to also be included. You don't just want a static image. There are also techniques that are based on DSC MRI or dynamic susceptibility contrast MRI or bolus tracking MRI that can help us understand a little bit better the status of the primary collaterals in a specific patient. Just to illustrate the importance of collaterals, what maybe perhaps not many people appreciate is that most people do not have a complete circle of Willis. The circle of Willis is incomplete in the majority of people, of normal people. So a person, for example, might not have or might have a very small kind of rudimentary posterior communicating artery as shown here. They might also be missing this part of the anterior cerebral artery as shown here. So if this vessel in this patient basically is blocked, like we saw last time, this time now there's no way that any kind of collateral blood flow can reach the area that it needs to, right? All the pathways are kind of, the main pathway is blocked and the other pathways simply do not exist in this person. And so that's the importance of keeping in mind collaterals when we're looking at individual stroke patients. There's also a different type of collaterals, sometimes called secondary collaterals or leptomeningeal collaterals. They're, again, can be assessed with similar techniques that we mentioned before for the primary collaterals. And this is just shown here, again, just a representation of the circle of Willis, but this time we have the arteries kind of branching out around the surface of the brain to the leptomeningeal area, so around the surface of the cortex, basically. So this here is a branch of, or the continuation of the anterior cerebral artery, and that is the branch or is a continuation of the middle cerebral artery. And you can see here they meet, right? They anastomose with each other on the cortical surface. And this is again important because if you have a patient who has a blockage of their left middle cerebral artery like that, so blood flow will no longer flow this way or very little through this middle cerebral artery, but there will be blood going through the anterior cerebral artery, through the anastomosis, and kind of going almost retrograde kind of into the area that is supplied by the middle cerebral artery. And the key thing to remember is that this all sounds kind of very, very nice, very useful, but the problem with, or the thing to keep in mind about collaterals is that they vary a lot between people. So the extent and the efficiency kind of these anastomoses vary a lot based on age, based on different cerebrovascular risk factors, based on different genetic factors. So there's no way kind of telling, without being able to image these things, there's no way of telling in much detail how good a person's collaterals are, a specific person's collaterals. So the next P is perfusion and penumbra. There are different techniques to measure blood flow or perfusion in the brain. You have CT perfusion, but you also have a different range of MRI-based perfusion measures like dynamic susceptibility contrast MRI, arterial spin labeling, and so on. One of them, which is kind of the focus of my research boldly, I'll be speaking about in quite a bit more detail in a few minutes. But there are really a lot of different techniques to measure perfusion using CT or MRI. And the reason why perfusion is so important in stroke is related to this concept of the ischemic penumbra. It's a very complicated, perhaps sometimes a little bit controversial topic. There's this kind of image, I think this diagram is very, very useful, I think, to help understand this. It comes from this review, and I think it's really useful. But I just put it here just to kind of explain that the ischemic penumbra is one thing. The ischemic penumbra is basically defined as tissue that exists after the onset of stroke, and this tissue is dysfunctional. So it is not functioning normally in terms of its like firing, action potentials, local field potentials, all that kind of thing, all that kind of stuff. But it is potentially salvageable. So this dysfunction is reversible. That's the characteristic, the core characteristic of the ischemic penumbra, is that if the ischemia is resolved, then that tissue has the potential to kind of going back to being normally functioning brain tissue. The controversy or the complications come, I think, when we try to operationalize the penumbra. we have no way of kind of directly, non-invasively in humans measuring the penumbra itself. So we create operational definitions for what the penumbra is in humans. And one of the most common operational definitions is this mismatch between what you see on diffusion-weighted imaging on MRI, what you call the infarct core, and what you see on perfusion-weighted imaging or perfusion MRI, what you call basically what you assume to be the penumbra. This diagram is really mostly there just to show that that's not entirely true, not always true, and it's much more complicated because there are just too many pathophysiological factors that kind of all go into this concept of the penumbra. But just to kind of explain how it works, you have here, for example, a patient in blue in the left MCA, so middle cerebral artery region, you have an infarct core shown in blue. And you can see this core if you do diffusion-weighted imaging. So this is diffusion-weighted imaging, and everything that's hyper intense here, everything that's bright, is assumed to be the infarct core. These are two separate patients. And then you do perfusion-weighted imaging, and you see that there's basically one of two scenarios. Either the perfusion lesion, the area of disturbed blood flow, is much larger than the core, as in this first patient here, or the perfusion lesion, so the area of hyperperfusion, is roughly the same size as the infarct core, as in the second patient. And basically, the way this operationalization works is that this patient here is assumed to have a large ischemic penumbra, while this patient at the bottom is assumed to have none or a negligible ischemic penumbra. And this is important because empirical studies have shown that, especially in patients who basically present beyond the time window for treatment, stroke treatments like thrombolysis. So thrombolysis, for example, is really only recommended, at least without this kind of advanced imaging, up to 4.5 hours after stroke symptom onset. Anything beyond that requires basically advanced imaging. You have to then prove that this patient specifically has tissue that is worth saving, or that is essentially not worth saving, but that is amenable to be salvaged. And the assumption is that this patient here has a large penumbra, so they have more to gain from this treatment that is, of course, also not without its own side effects, than this patient here, who essentially has nothing to gain from the treatment. And then, of course, perfusion-weighted imaging can also be used then to assess the treatment response. So the infarct core is assumed to stay more or less the same because it is essentially considered to be kind of non-viable tissue. That is a controversial topic on its own, but just kind of as a broad generalization, while the perfusion lesion is assumed to be reversible, which in this case, for example, it was. The patient was treated, and then the perfusion lesion disappeared. And then just to go back, perfusion, when we talk about perfusion and penumbra, we just need to think about those criteria that we kind of set ourselves from the beginning for any kind of imaging technique that we want to apply to stroke patients. So remember, it has to be fast. I think most of the perfusion imaging tools based on MRI that we have at the moment are relatively fast. It also has to be minimally invasive, and that's when things start to get a little bit complicated. DSC MRI, for example, requires the use of contrast agents. CT perfusion requires also the use of contrast agents, and it exposes patients to ionizing radiation, which is the vast majority of cases where it's clear the patient has a stroke, basically, is definitely justifiable. Basically, you can justify exposing the patient to that ionizing radiation because the benefit far outweighs the risks. But there are certain situations where you have to think twice, I think. And of course, it also has to be robust, as we mentioned earlier. And then you have techniques like arterial spin labeling, which I think are excellent techniques, but they come with their kind of own difficulties in interpreting the data in patients who have, for example, cerebrovascular diseases like large vessel atherosclerosis. And techniques like arterial spin labeling are also relatively sensitive to motion, simply because the SNR tends to be small or smaller than other techniques. And that's why I wanted to speak to you about, mostly about this technique that we've been working on and trying to validate and improve over the past decade or so. And that's this bold delay technique. And it's basically based on, you just acquire a kind of standard resting state functional MRI acquisition. And what you can then do is you can perform this kind of voxel-wise cross-correlation with, between each, the signal, the bold signal across across time in each of the voxels versus a reference. So you're cross-correlating the voxel time series, each voxel's time series, with some kind of reference. This reference can be the global, the mean signal in the entire, across the entire brain. It can also be kind of the venous outflow tract of the brain, so the large venous sinuses. But basically, the idea is the same. You perform this cross correlation voxel-wise, and when you do that, when you perform this cross correlation, you can identify essentially lags or delays. So you can say that essentially this this time series here in this red voxel is delayed by about 10 seconds compared to the reference. If you do this for the entire brain, you end up with a map that looks like this, where these kind of more yellow colors show voxels that are delayed compared to the reference, while the blue colors show voxels that come early, that lead the reference. And this actually tells you some really interesting things about the brain hemodynamics and about blood flow within the brain. And this was first shown in almost about 10 years ago in this kind of proof of principle study. Each one of these rows, and so each one of these basically is a patient, and we see their diffusion weighted imaging in the first row, their DSC MRI, specifically I think the MTT, the mean transit time map, in the middle row, and then the bold delay in the lower row. And basically these were all acute stroke patients, and the authors basically saw very good, very close visual correspondence between the perfusion lesions derived from DSC MRI and the ones derived from bold delay. And over the past 10 years, a lot more has been done using this technique. It's been expanded to other clinical contexts as well, so not just acute stroke, but all kinds of chronic cerebrovascular disorders, also some patients with, even in neurologically normal individuals, patients with different types of dementias, brain tumors, and so on. And a lot of different comparisons have been made between the technique and DSC MRI, ASL, SPECT, other perfusion imaging techniques. So these are just the results of some of the more quantitative validations that have been done using this technique. So this paper from 2015 by Kristen et al. Compared quantitatively, again, bold delay basically to Tmax derived from, or time to maximum derived from DSC, and saw pretty good correlation between the two metrics. Siegel et al. Then did it with ASL, again, a relatively good correlation between the two metrics. And then we did the same about 5 or 6 years ago, looking across different, kind of comparing bold delay to a bunch of different perfusion parameters derived from DSC MRI, and found that you actually get the highest correlation when you compare bold delay to time to maximum from DSC. So this kind of showed that it's a perfusion parameter that is very sensitive to delays, right? So it's a delay parameter. It's Tmax is essentially not telling you that much, I think, about the microvasculature and like CBV or CBF does kind of, but it more tells you about how long it takes for blood to arrive, the arrival time of the blood basically in a certain region. And then we went on to kind of show that this technique can also be really useful for monitoring stroke patients over time. So this is just an example from this study. There's a patient with a occlusion of their left-sided posterior cerebral artery here pretty distally. It's a bit hard to see, but if you look at the symmetry here, the right posterior cerebral artery is all kind of normally, there's normal flow in it, while the left one just kind of ends abruptly. And then you see here the perfusion maps from bold delay. So there's this and the left occipital lobe, basically corresponding to the perfusion territory of this vessel. You see this perfusion lesion that matches the lesion that you see on Tmax as well. And after treatment, the vessel is patent again, so it opens up, right? So you see more vessel here, kind of distally, and these both on the Boltley and on the Tmax maps, you see a recovery of this hyperperfusion or this delayed perfusion that we saw earlier. And the important thing is that the kind of inverse of that is also true. So this is a patient who had a right-sided MCA occlusion. So the MCA is blocked here at its origin, or very close to its origin, on day 0. And the next day, the vessel was still blocked. And you see this persistence, basically, of the perfusion lesion on corresponding to that blocked artery on both the Boltley and the Tmax maps. We then went on to, because as I mentioned earlier, speed is really, really important in the context of acute stroke, to kind of look at whether we can make the scans even faster. The scans were about almost 6 minutes long when we started. And what we did was we just kind of took this 6-minute long resting state scan and we broke it down into smaller parts. And then we analyzed and calculated the Boltley maps from each of these shorter parts. And we found that you can actually shorten the scan time quite a bit. So you can shave off, what is this, probably about a minute and a half or so from the full scan length before you start to really see a deterioration in the maps. So the maps that are derived from kind of the 3 longest scan times all look quite similar. There's not that much noise in them, while the ones that are kind of from the very, very short scans start to get really noisy and difficult to interpret. And this was something that basically clinicians or radiologists who took a look at the maps also kind of agreed with the first with the 3 longest scans. The interpretability was judged as being pretty much the same, while it only kind of started to deteriorate at the 2 shortest scan lengths. And that really, especially that last study, really helped us kind of try to implement this technique, basically Boltley, in the clinical routine a little bit more. So what we have now is a setup in our center where the patients come in. If they have no contraindications to MRI, and if they come in during kind of the MRI working hours, they get MRI. And very often what they get is a resting state fMRI scan that lasts just a couple of minutes. And this scan can then be kind of immediately by the radiologist kind of on duty, can be immediately, with just really a few clicks, just 2 or 3 clicks, can be immediately analyzed, processed in real time, and the results are then kind of visualized to both the radiologist and the treating clinician in order to help make decisions about how to treat these patients. So we have this all kind of wrapped into this software platform called Nora that we use, and this has been very, very helpful. And then exactly treatment decisions can be made after that. I'm just gonna have to skip through this a little bit because I think I'm a bit short on time, but just so far we've been kind of talking mostly about lags and this idea of Boltley, but of course we know that perfusion, hyperperfusion changes in blood flow are reflected in the Bolt signal in ways that go just beyond delays. So you have the delays, this is what I spoke about so far, but you also have changes in frequency of the Bolt signal that are related to changes in blood flow or perfusion. You also have changes in amplitude. And so in this next study, we tried to kind of see if we can take advantage of all these changes in order to help us visualize blood flow using Bolt-based imaging, so resting state fMRI, even more. So this is from one of our more recent studies. Each of these rows is a patient, is an acute stroke patient, basically. On the right side here, you see the perfusion lesions detected using Tmax, so DSC MRI-based perfusion parameters. And what we found is that using spatial independent component analysis, so spatial ICA, which is of course a technique that's able to kind of break down kind of a complex signal like the Bolt signal, which is kind of made up of different constituent parts into smaller parts that are more easily interpretable, hopefully. What you get when you perform the spatial ICA on resting state fMRI patient data from acute stroke patients is you get these what we call hyperperfusion independent components, which are really just independent components that visually, in terms of their spatial overlap, also resemble a lot these perfusion lesions that are derived from more conventional techniques like DSC MRI. So that's shown here for these 3 patients. But what's really, I think, exciting and interesting about this is that even in situations where, as I mentioned before, like patients move a lot during the scan, like this patient here has a right-sided MCA stroke, middle cerebral artery stroke, and during their resting state fMRI, they moved quite a bit, and the resulting bolt delay map was completely uninterpretable because of the motion. But what's interesting is if you apply spatial ICA to the same data, then what you're able to basically recover this component that, again, visually just bears a very striking similarity to the perfusion lesions derived from DSC MRI. And we then went on to show basically that they're using just a set of a very kind of a small set of characteristics. You're able to kind of automatically differentiate from between this hyperperfusion related component and all the other components in the resting state fMRI data. So things like the resting state networks, but also like different vascular, venous, arterial signals and motion signals and scanner noise. You can basically pick out the these hyperperfusion components using, again, a relatively small set of signal characteristics. And you can do this with quite good accuracy. So I'm just going to spend the last few minutes just talking about performance. What I mean basically when I talk about this last P, performance, is really the function of the tissue. This is different to tissue viability, which is kind of something that maybe diffusion-weighted imaging more tells you about. It's really about, okay, this tissue might be viable, but is it functioning normally, or is it basically is its function somehow disturbed? And this can mean, again, a whole host of different things. Most of the time when we speak about, or when I speak about performance, I'm talking about functional organization and connectivity of the brain or within the brain. But there's also things like responses to increased metabolic load, so things like cerebrovascular reactivity that would also fall into this key of performance. And we've known for a while now that basically the state of the brain's functional organization after acute stroke really kind of tells us some really interesting things that perhaps are even or could be at some point clinically relevant. There's this paper by Siegel et al. That basically showed that impairments in certain functional domains, like visual domains, verbal memory, and so on, they're much better predicted by changes in functional connectivity than they are by just the location, the anatomical location of the stroke. And then there's studies like this, basically, which showed that the specific patterns of functional connectivity just a few days after stroke onset is basically an independent predictor of stroke outcome months later, 3 months later. And we've been kind of exploring, looking at functional connectivity in the context of acute stroke in a number of different ways. One of these ways is kind of to try to move away from kind of discrete, or trying to break down the functional organization of the brain into kind of discrete, almost kind of arbitrary networks, into more kind of continuous approaches. So there's this concept of functional gradients, for example, that was introduced, or at least pioneered, by Daniel Margulis and colleagues in 2016, that basically tries to place the functional organization of the brain along these kind of continua. So you have a continuum here, for example, this first gradient, where on one end you have kind of unimodal areas, visual areas, speech areas, so on. And on the other end, you have more like what are called transmodal areas, or areas that are been traditionally kind of linked to the default mode network and so on, but they all exist kind of within this kind of continuum. That's a really interesting way of looking basically at the functional organization of the brain. especially I think in kind of diseases or conditions where you have a discrete lesion, like in stroke, or at least a set of discrete lesions, because you're able to do very interesting things looking at changes in connectivity over time as defined or within the context of these gradients, and try to explore how the lesion has an influence on these changes, or at least is related to these changes in connectivity over time. Other approaches I also think are really interesting, like, for example, lesion network mapping, where you can basically say, okay, I don't really need necessarily the functional MRI data. I'm going to use a template, a normative connectome, for example, derived from hundreds or thousands of patients. And I'm going to use that to see, to look at connections, what the lesions basically that I have in these stroke patients are likely to be connected to, and build essentially models of disorganization and reorganization of the brain after stroke based on these things. And the whole point of this, of course, to then be able to say, okay, using all these techniques, I might be able to identify on an individual level some kind of unique connectomic fingerprint, some kind of functional or a specific set of changes in functional organization that I can then use, for example, to help in a more personalized way treat patients with things like non-invasive brain stimulation, for example. We're still quite far away from that goal, but that's kind of the idea. And I think the methodological developments that have been happening over the past decade or so have really been crucial in helping us gradually kind of realize that goal. So I'm just gonna have to skip through this, sorry, just because I'm a bit over time. But basically, I spent most of the time talking about like this vascular aspect of things, which is mostly what my research is about. And this concept of Baudelaire is I think, or this technique Baudelaire is really interesting, I think, because it allows you in a non-invasive way, so you don't need to give the patient any kind of contrast agent. You put the patient in the scanner and basically run a resting state sequence to assess hemodynamics and blood flow in stroke patients. It's quite an accurate way. It's relatively efficient with a short scanning time, and it's also crucially, it's sensitive to changes over time in perfusion that happen. And then on the functional or the kind of performance side, there's been a move, of course, from these kind of more discrete to more continuous approaches. We're starting to look more into these techniques that help us leverage more kind of already existing data, like data sets that only have, for example, stroke lesions, but don't necessarily have functional MRI data or structural MRI data, or sorry, DTI data or something like that. And these things might also help us guide treatment of stroke patients in the future. One thing that I kind of skipped over towards the end is that these two things, the vascular and the functional, really interact with each other very closely. And you cannot really think of one without considering the other. So especially in a disease like stroke, where we know that there are derangements in both the vascular and the functional, you really have to kind of think carefully about how you're interpreting when you're only interested in your data, when you're only interested in looking at one or the other. There's also a bunch of other really interesting emerging techniques that have been or that are derived from resting state functional MRI and are relevant to stroke that I just, of course, had no time to go over today, but are really, really interesting. There's people looking at large vessel imaging in stroke using resting state fMRI, quantitative MRI techniques for measuring tissue oxygenation, the cerebrovascular activity work that's been done over the past few years that I mentioned earlier. And I think those are also those are things that are very likely to become clinically relevant over the next few years. And with that, I'd like to thank you for your attention. Sorry that I went a little bit over time. Sorry about that. And yeah, happy to take any questions.